Yeah, aloha everyone. Welcome to the Queen's free Speaking of Health lecture series. Tonight's lecture is called Advanced Heart Failure, New Treatments and Choices. My name is Sean Ibarra. I'm from the Corporate Communications Department here at Queen's, and on behalf of the Queen's Health Systems, we want to welcome you to tonight's lecture. So our presenter this evening is Dr. Deepanjan Banerjee. He is the Director of the Advanced Heart Failure Program at the Queen's Medical Center, and a faculty member at the University of Hawaii John A. Burns School of Medicine. As a heart failure cardiologist, he cares for patients with a wide range of heart failure. Dr. Banerjee also evaluates patients for specialized valve procedures, pacemakers, heart assist devices, and heart transplants as well. He is a member of the American College of Cardiology and the International Society of Heart and Lung Transplantation. So let's please give a warm welcome to Dr. Banerjee, who will be giving our presentation tonight. Doctor?
Aloha, everyone. Can you hear me? Okay. Well, thank you very much for that kind presentation, and thanks everyone for coming to this talk. I think heart failure can be a scary term, and it can be even scarier if you have it. And so what I hope to do during this talk is to dispel some myths about heart failure and show you that it's something that's actually very treatable and more common than you think. And we're excited to have an advanced heart failure program at Queen's because we think it's going to help the community and many of the people in Hawaii. So the outline of the talk is basically, what is heart failure? I think it's a nebulous term. It's kind of confusing. And again, it's really scary. So we'll talk in a little bit of detail about what we mean when we say heart failure to a patient. We'll talk about what the problem is with having heart failure, even if it seems a bit obvious. And mostly I'll be talking about how we treat heart failure. And I'll be basically telling you the same things that I tell patients in my clinic. And then finally, again, we are excited. And I know that some of the heart failure team members are here in the back, Mandy Cummings and Erin Suzuki, who were a big reason why I came to Queen's in the first place. And so we will be discussing what our new initiatives are in terms of taking care of heart failure patients, not just at Queen's, but in all of Hawaii. So what is heart failure? You may see this abbreviation CHF. Well, that stands for congestive heart failure. But that's just a description, and it basically means that someone's heart is not working. And we typically think, in terms of heart failure, of a problem with the pump. The heart's a pump, and it pumps blood to the rest of the body. It pumps blood to your body, but it also pumps blood to your lungs. So you can have a problem where the pump is weak and doesn't get enough blood to the rest of the body. But something we don't think about too often is that the pump has to receive blood from the rest of the body. Right? It's just like if you had a car engine, the car engine needs oil and it has to intake that oil so that it can output energy and drive the wheels of the car. So if your heart can't receive blood in a normal fashion, a patient also can develop heart failure. And we'll talk about that in a bit more detail. And it turns out that one of the biggest problems in heart failure is the body's response. The way I would explain it to a patient in clinic is, hey, when you have heart failure, it's not just your heart that's suffering, it's the rest of your body. The other organs in the body are not getting enough blood. And when they don't get enough blood, they react, and sometimes they react badly. And that can be part of the problem as heart failure progresses, not just the heart, but the other organs too. So I think the other important part about heart failure is that it's not rare. We know that in our clinic, and I think every emergency department knows that because one of the major reasons that people present to the emergency department is for problems with worsening heart failure. But if you think overall to admissions to hospitals in the United States, it's about 3% of admissions, which doesn't sound like much, but that's a big proportion, one of the main reasons people come to hospital. And it also doesn't sound like much, but the percent of people in the United States with heart failure is supposed to go up by about 0.7% in the next 20 years or so. And 0.7% doesn't sound like much. It sounds almost like a a mortgage or something like that. But this is a mortgage that pays off rather badly, right? Because if you think about our population, it's 350 million people. So that means that there's going to be 5 million more people with heart failure in the next 20 years. And that's a lot of people, right? Hawaii has about 1.5 million. So that's 3 times the population of Hawaii having heart failure. That's an island no one would want to live on, right? So we have to really figure out how we're going to prevent this epidemic and also treat the patients who develop significant heart failure. So to think about it on more simpler terms, there's 2 sides of your heart. I talked about the heart being a pump and supplying blood to the rest of the body, right? So the left side of your heart pushes blood to the whole body, your brain, your kidneys, your arms and legs, so you can exercise more. And the right side of your heart pumps blood to your lungs. So that's a very simple way to think about it. But as I discussed before, the other distinction in heart failure is if you have a pump problem, and the doctor term for that is systolic, or if you have a relaxation problem, a problem receiving blood in your heart, and the doctor term for that is diastolic. And I'm bringing these terms up not because I think you need to memorize them, but these are things that your doctor might tell you about. And I think you guys are pretty smart. I want you to know the terminology and know what they're telling you when they say these words. So typically when people think of heart failure, they feel, okay, I'm going to be tired, I'm going to be short of breath, but there are some small differences and some not so subtle differences in between left and right-sided heart failure. So because left-sided heart failure affects most of the organs in the body, it's really your brain and your kidney that get affected the most. And as you might imagine, you can get tired because you're not getting enough blood to your arms and legs. Your kidneys might suffer, and you might develop mild kidney failure. You might be thinking a bit more slowly because you're not getting enough blood to your brain. On the other hand, if you didn't eat lunch, you could also be thinking more slowly. So just because you didn't eat lunch doesn't mean you have heart failure. So that's one big problem with heart failure, is that many of the symptoms that you have with heart failure are symptoms of other things too. That's why it's really important to have a good physician or nurse practitioner or some healthcare provider that knows you and can help guide you through those symptoms. In terms of right-sided heart failure, this is the big difference, I would say, is that there's a lot more swelling, because the right side of the heart gets blood from the rest of the body and also from the liver. And so when I have a patient with right-sided heart failure, those patients tend to complain a lot of bloating. I just saw a patient in clinic today, and she was telling me, yeah, I feel bloated, and it's because the right side of her heart is working less well than the left side of her heart. And so these are the patients also who get a lot of swelling in their legs. One problem with the right-sided heart failure, which we'll talk about, is there's not as great medications to treat that as there are for left-sided heart failure. So the other big distinction that we talked about was the pump problem versus the relaxation problem. So remember, the pump problem is called systolic heart failure, where the pump just isn't pumping enough blood, it's too weak. And this is a point that I want to go over in some detail. How do we measure pump function, right? So I can't just look at you and tell you what your heart function is. So there are a number of things that we do. One of the easiest things we can do is actually do an ultrasound. It's not a painful test. It doesn't harm you in any way. And it can get us a lot of information, not just about how the heart is functioning, but potentially what is causing the problems with the heart. And so that's an ultrasound right there of the heart. And this is the left side of the heart, the left ventricle, which pumps most of the blood to the body. This is the RV, or right ventricle, which pumps blood to the lungs. This is the left atrium, which receives blood from the rest of the body. And this is the right atrium, which receives blood, receives blood from the lungs. And this is the right atrium that receives blood from the rest of the body. So when we get an ultrasound, we can look at how big the chambers are in the heart. That tells us something. It may tell us a little bit about how long someone's had heart failure. The longer they've had it, typically the bigger the heart gets, right? We can look at valve problems in the heart. We can see if there's a leaky valve or a valve that is too narrow, and that can give us an idea of what's causing the heart problem. And then we can get this measurement called ejection fraction. That sounds really high tech, but it's actually pretty crude. It's basically a measure of how much blood's in the heart and then what % of that gets pushed out with each beat. So a lot of times a patient will come to me and say, my ejection fraction is 40%. Am I going to drop down tomorrow, you know? Well, that sounds pretty bad, 40%. Well, it turns out that normal is 55 to 60%. So when we say someone's ejection fraction is 40%, that's actually 2/3 of normal. It's not 40% of normal. So that can be a bit reassuring for people. And it also turns out, I don't tend to worry too much about the number. I know patients worry about it because it's something that you can follow. But I have patients who have an ejection fraction that's 25% that feel great and they can do everything that they want. But I have patients who have an ejection fraction of 45% who can hardly do anything and are really short of breath. So I tell patients in clinic, look, you know, would you rather have a higher number and feel worse or a lower number and feel better? And they usually tell me they'd rather have the higher number and feel worse. So I try to educate them a little bit about, well, that's fine, but you know, I'd rather you felt better. So as I mentioned, you know, this ultrasound of the heart can tell you why you're having a heart problem. And unfortunately, and this is not just true of Hawaii, these causes are very common. High blood pressure, diabetes, a lot of people have those conditions. If you've had a heart attack or you have reduced blood flow in the arteries of your heart, that can cause a weak heart. We talked about heart valve problems. That can be either due to a leaky valve, and I'll talk about that in a bit more detail later, or a valve that's too narrow. It's not allowing blood to get where it needs to be. Finally, you can have substance abuse, such as too much alcohol use. People would say, well, what's too much? You know, is it 5 drinks at a time? It turns out that there's pretty good data that if you know, for women, you shouldn't be drinking more than 7 drinks in a week. And then for men, not more than 14. And probably if you do have a weak heart, you should be drinking less than that. So that's just a ballpark. When I first see a patient in clinic and they do have a weak heart, what I tell them is let's try to do everything we can to get the heart better. Because if the heart doesn't get better, then you're stuck. You know, then we're talking about a heart transplant or a heart pump. And so I do try to tell patients not to use any alcohol until we've gotten the heart in better shape. We'll talk about it more extensively, but amphetamines, like methamphetamines, or even things like Adderall, a medication that's often used for adolescents, you know, teenagers who are trying to cram for tests, right, to improve their attention span. That's an amphetamine. One question I always ask my patients in clinic is, do you use weight loss drugs? And they kind of look at me funny. Do you think I'm fat? But that's not why I'm asking the question. I'm asking the question because that many weight loss drugs are amphetamine-like compounds. And I've had patients who've developed heart failure just because they use weight loss drugs. So if you come to my clinic, be prepared that I will ask you that question. I think finally, it can be very frustrating when people don't know why they have heart failure. We are in an exciting time, and more we're being able to figure out why someone has a weak heart or a stiff heart. But at the end of the day, a lot of times we don't know. And I think that what it comes down to is someone has bad luck. They had some genetic abnormality that predisposes them to heart failure, and then something happened in the environment, like they had a virus attack their heart, or they had some other exposure, and that caused their heart to become weak. Another example I would give you is, you know, a lot of people drink alcohol, but not everyone develops heart failure who drinks alcohol. So there must be something in the people who developed heart failure that made them unlucky or more likely to be susceptible to the effects of alcohol. The good news, after all that bad news that I just gave you, or the bad things I talked about, is that there are a lot of therapies that we can use now to improve function in patients with heart failure. What about the other side of the coin? Although I would say it's not really the other side of the coin. When your heart doesn't relax normally, when it's too stiff. So that's called diastolic heart failure. And actually, half of the patients in my clinic have diastolic heart failure, and the number is just rising. It turns out that it's a disease of aging. The older people get, the stiffer their heart gets. And that's partly due to the fact that many of the conditions that cause stiffening of the heart come with age, like higher blood pressure. As we age, our blood pressure goes up, or diabetes. People tend to get more diabetes the older they get. One interesting aspect of the stiff heart problem is that women tend to get it a bit more than men. And people who have high blood pressure tend to get it a bit more. A lot of people think, well, my heart function, I have a stiff heart, that's not too bad, right? I must not have had a heart attack. And that's not true either. It turns out that people who have the stiff heart have as much disease in the arteries of their heart as people who have a weak heart. So I do usually check for the arteries of the heart in anyone I see in my clinic who has a stiff heart. And people think, well, it's a stiff heart, that's not good, but at least I'm going to live longer than someone who has a weak heart. And that doesn't turn out to be the case either, unfortunately. It turns out that if you have a stiff heart, probably because people are older, probably because they have other conditions that make the heart stiff, like high blood pressure and diabetes, they have the same rate of lifespan as patients who have a weak heart. And I think the really unfortunate thing, although this is changing, is that we don't have as many therapies to improve a stiff heart as we do to improve a weak heart. So another thing your physician or nurse practitioner or person who sees you in clinic might tell you is, okay, well, I think you have this severity of heart failure. So how do we determine how severe someone's heart failure is? Well, this is just as crude as the ejection fraction measurement that I told you. So it turns out you can say, well, you have a class of heart failure, and there's 4 different classes, and you'd rather have the lower class. You'd rather have class 1. Class 4 is the worst. And this is just sort of a shorthand that we use in our clinic to determine whether someone is getting worse in terms of the symptoms or not. Class 1 is you're not limited at all, which I hope is true of all of you in the audience. And class 4 means, okay, you can't do anything without getting short of breath. Most people that I see in clinic are class 2 or class 3. They get short of breath with a little bit of activity or short of breath with extraordinary activity. And that's how we do the bookkeeping to say, okay, the last clinic visit, this person was this class, now they're worse or they're better. But I think it's a bit more useful, and I think probably more useful for you to think of heart failure as a stage and a progressive disease. So this was a classification scheme that came out about 2006 out of the University of Pennsylvania. And what they said was, look, heart failure gets worse over time. I mean, there are patients that get better and go back to normal, but overall, the condition is a worsening. And so it doesn't make sense to just talk about symptoms. We want to talk about someone's risk when they have heart failure. So they came up with 4 different stages. So stage A is if you're high risk for heart failure, but you don't have symptoms. So maybe you have high blood pressure, maybe you have diabetes, and we're worried about you developing heart failure, but you don't have it yet. Stage B is if you don't have any symptoms, but you have something wrong with your heart. Your heart is stiff or your heart is weak. And these patients sometimes just get picked up, routinely. They had a cough, they got some testing in the hospital, and something showed up that made the physician or the clinician say, let's get an ultrasound of the heart, and that's how the heart failure was diagnosed. But that's good, because then we can start therapy for that patient even before they develop symptoms and maybe prevent them from having symptoms. The majority of patients I see in my clinic are stage C. So these are patients who have something wrong with their heart, and they were sent to my clinic because they have symptoms, right? There's something wrong, and we're trying to get them better. I specialize too in stage D heart failure. So these are patients who've had symptoms, and we've tried almost everything. We've tried medications, we've tried special pacemakers, and despite all of those things, the patient is still suffering. And those patients still have options, which we'll talk about, which include a heart transplant, a heart pump. And I'd be remiss if I didn't talk about palliative care. Palliative care is a kind of therapy for patients who are not thriving despite medications, and it's moving away from trying to cure them and focusing more on improving their symptoms. And that is definitely a therapy that we use for patients with heart failure. And ironically, it turns out to prolong patients' lives and give them a better quality of life. So heart failure is bad. I don't think that we would call it heart failure if there wasn't anything bad about it. And as I mentioned, it's pretty prevalent. It turns out that if you're 80 years old, and no one here in this audience looks like they're 80, everyone looks like they're 50 or younger, the risk of heart failure if you're 80 years old is 1 in 5. And so it's not like you get to 80 and you've not had heart failure and you have a get out of jail free card. You still have a risk of having heart failure. And so the concerning thing, and this is slightly old data, was, gosh, before we had therapies for heart failure, the outcome was really poor. So the mortality rate, people dying, was 1 out of 5 in 1 year and 4 out of 5 in 8 years. But that's really changed, and we'll talk about why. But since the 1950s, when some of the heart failure therapies came out, and now in the 2000s, the rates of heart failure mortality have decreased substantially. So we talked a little bit about symptoms, and I just want to emphasize this again. And I don't want you all to go home because you'll probably be a little bit tired after working all day to think that you have heart failure. But remember, weakness, fatigue, those are signs of heart failure, shortness of breath. But it turns out that you can tease these out, right? If you gain weight, and I said this before, it could be because you went to Zippy's every day for a month, or it could be a sudden weight gain over 2 or 3 days. And that is not usually flesh, that's usually fluid. So that would be a sign of heart failure. Or if you get shorter breath just walking to the mailbox, that might be a sign of heart failure. There's a new, there's all this new research coming out. And actually, there's a group in Texas who came up with a new sign of heart failure, which is if you bend down and you get short of breath, that could be a sign of heart failure. It's called bendopnea. I think they were just trying to publish more papers, but we'll see. So how do we treat heart failure? When a patient comes to clinic, I think sometimes they get scared. Oh, he's going to throw some more medications at me, or they're going to talk about a pacemaker. The first thing I talk about when a patient comes to clinic is diet. And that's why we're so lucky to have Aaron and Mandy and the whole team talking to patients and educating them about salt. So I do want to spend a bit of time on this because that's the bulk of the time I spend in clinic. I spend about 30 minutes talking to patients about salt in clinic for a new patient. And I want to be a bit more precise about it. So when you talk to patients about salt, they say, well, okay, how many milligrams of salt should I get in a day? Is it 2,000 milligrams? Is it 1,500 milligrams? It might surprise you to know that I never tell patients how many milligrams of salt they can get because I'm really bad at math. And so if I told patients how many milligrams of salt, they would have to add it all up and multiply it by the number of servings. And unless you're a math genius, that's really difficult to do. So my diet is more drastic, but it's easier to follow. And I tell my patients they just should have no added salt in their diet. And that means reading labels. It is a bit more involved. And so if you go to the grocery store, I don't know what they have here, Foodland maybe, Safeway. And so I just moved here. So if you go to the grocery store, everything has labels now because everything is so overregulated. So what I tell my patients is go read the label, but don't look at the percent sodium. Don't look at the milligrams of sodium. Just look at the ingredients. Everything has an ingredient. If you buy bananas at Costco, it'll say ingredient banana. So you can have that, right? But if it says salt in the ingredients, then that's a food that you should not have. So that's what I tell my patients, and that's what we talk about. Usually they tell me, well, you've ruined my life. I can't eat anything. What can I eat? But that's not true. For breakfast, you can have shredded wheat or oatmeal. That doesn't have salt in it. You might think that Cheerios is in this diet, but it's not, right? Cheerios, even though they call it heart healthy, has salt added to it. Whereas frosted mini wheats, which doesn't sound healthy at all, has no salt added to it. But I recommend the non-frosted mini wheats because it's better for diabetics. So there's a lot of things that you can do, and I think we'll have some handouts to talk about that. But a lot of people might ask, well, what's the evidence for that? I think there's 2 major pieces of evidence. One of them is common sense. Like the Yanomami Indians in the Amazon rainforest, guess what they eat? They don't eat a very salty diet. They eat, fresh, I don't know what they eat, vegetables and things like that. But they don't have salt, and so they tend not to die of any heart disease. They die from parasites, but that's another story, right? But you guys don't have a parasite problem, right? So I think the idea is that we should all eat less salt. And it's interesting, this paper just came out, I think, 2 days ago. But there was a governmental directive in United Kingdom, in England, to say, oh, let's put less salt in the diet. But then they overturned it because maybe the people rebelled or something. But anyway, they overturned it. And what happened was there was a lot more heart disease after they overturned it. So that's the evidence, is that and that's not even for a heart failure patient population. That's just for the general population. So we know that we get too much salt in America and in Hawaii. So it's really a matter of negotiating with patients. And I think we're pretty good at that, about how we can put a dent in that salt intake. What about lifestyle? So a lot of patients will tell me, you know what, I'm so short of breath, and I feel bad for them. Even when I walk for 10 minutes, I get tired. And I understand that. That is one of the big problems with heart failure. And the problem is that it's a self-perpetuating cycle. Patients don't want to walk because they get tired. They can't walk. They get more tired. Their heart gets worse. There's great evidence that the more you walk, and the better your heart gets in patients with heart failure, the longer that you live. But it's hard to tell patients, how much should you walk? What I tell patients is walk 30 minutes a day, every day, even though it says 5 days a week there. I basically tell patients walk on the days that you eat, right? Yes. And then I'll have some patients. I had a patient today who said, I want to start fasting. So then I have to come up with some different, admonition for that patient. But in any case, if a patient can't walk or someone can't walk for 30 minutes, I say, look, go to a park. They have benches at parks, right? So you walk from bench to bench, and when you get tired, sit down. And when you've recovered, start walking again. You don't have to do it all at once. And I think we want to be practical, right? I'm pretty busy, and there was a time a couple of years ago where I was gaining a lot of weight. And so I thought, this is terrible, what can I do? So I decided to start running to work. That was the only time I could figure out to do any exercise. So then I started running to work and I lost the weight. I know that's not possible for everyone, especially if you don't have a shower at work. But I think that it's still important to try to fit it around your schedule, right? And so walking on your lunch break, walking up the stairs. I know some of our staff does that. There are ways that you can incorporate that into your daily routine. And we're not talking about I don't ask patients to do an Ironman triathlon. We're talking about brisk walking. Water aerobics counts. I didn't think that it counted, but it does count. And so there are things that you can do that are things that you're capable of doing and that you can fit into your day. So I wouldn't be here if it were just sort of diet and exercise. There is a component of medications to all of this. And so I think I do want to emphasize that it's important for you to understand why you take medications. I never try to throw pills at patients because I don't think that patients like that, because it hurts when you throw pills at patients, but also because if you don't understand why you're taking the medications, then you're not going to take medications. And so, again, I think patients are pretty smart, and so I do try to explain to them why they're taking medications. And I won't go over this in great detail, but basically, remember we talked about the fact that when you have heart failure, your heart is really weak. And it turns out the body doesn't like not getting enough blood. And your brain is the most powerful organ in your body, which you all are aware of. When the brain doesn't get enough blood, it starts sending hormones to the heart to make them work harder. Well, you know that hormone, it's called adrenaline. When you're crossing the street on, I don't know what a big street is here, Beretania Street, Ala Moana, in the Ala Moana Mall, right? That's a busy place. And a car is about to hit you, you can get a surge of adrenaline. You can jump out of the way. So adrenaline can be life-saving. The problem in heart failure is that the adrenaline's there all the time because your heart is weak all the time, and that's bad. And so the research that was done initially for heart failure showed that, wow, there's high levels of adrenaline in the body that makes the heart work harder, and then the heart starts scarring and starts getting bigger. So the heart gets bigger, cells in the heart die and get replaced with scar tissue. And there's other hormones that get activated in the body. There's hormones from your kidneys that start retaining fluid, right? So remember I said the kidneys also don't get enough blood. Well, the kidneys are not as powerful as your brain. So the kidneys say, hey, I'm not getting enough blood. How can I get more blood? The only way the kidneys can get more blood is by holding on to blood. But it's not blood that they hold on to, it's water. And the way they hold on to water is by holding on to salt. And that's why I'm so severe with my patients. We're probably the most strict clinic in the country about salt, because that's one of the best ways to combat heart failure. But all of these hormones that get secreted in heart failure are treatment targets. That's why we give you medications, is because those medications block the effect of these hormones. So it's not for your blood pressure. This is just a schematic of all the medications that we use. But they all sort of work on the heart or the kidney or the arteries to reduce stress on the heart and basically allow the heart to relax and to recover. So there's a class of medication called beta blockers. It's pretty simple. They directly block the effect of adrenaline on your heart. That's the best medication that we have for heart failure. And so they actually slow your heart down. They slow the pumping function of your heart down. And so one of the problems is that initially when someone starts that medication, they might feel a bit more tired. And a patient will say, well, why do I want to feel more tired? That doesn't sound very good. But what I tell patients is, look, it's like changing gears in a truck. You start the medication, and first you feel a little bit more tired, but after a couple weeks, you change gears. And then you get more energy. And in the long run, this pays off because your heart gets stronger. So this study was actually done partly at Stanford. It was the U.S. carvedilol heart failure study. And what they showed was that just getting on this one medication led to 5% less patients dying in 2 years. It doesn't sound like too much, but it's just a pill. Taking this one pill means 1 in 20 patients didn't die in 2 years. And if you look at treatments across the country for medications, that is really good, especially because this is a medication you can now get for $4 a month at Walmart, even if you don't have insurance. So these medication has been around for long enough and is so good that I can give it to any patient, even if they don't have insurance, which is, I think, a real positive about heart failure. There are other medications that we use called ACE inhibitors. These block the effect of renin on the body. And a lot of patients say, oh, you're giving me a medication for my blood pressure. My blood pressure is normal, or my blood pressure is low. But again, we're not giving this medication for blood pressure. We're giving this medication because it works with beta blockers to block the effect of adrenaline on the heart. And these medications also allow patients to live longer. There's another class that's very similar to ACE inhibitors called angiotensin receptor blockers. I won't go into detail, but it's very similar in terms of its effect. This is a medication that you may have heard of that's new. It's called Entresto. The trade name is sacubitril valsartan, so you can see why they called it Entresto. But basically, this is a medication that incorporates one of the older therapies for heart failure, angiotensin receptor blockers, but it added something new, this sacubitril. But basically, it's one of the only medications in the last 5 years that's been shown to reduce death and improve life in patients with heart failure. It was a huge trial. It came out in about 2015, and it was about 10,000 patients. But what they showed was a really big decrease in mortality, a 20% reduction in relative risk reduction in mortality, which is actually about 2%. But this is a medication that we hear about a lot now, and I use a lot in patients who are not tolerating or progressing despite their prior therapy. So I bring this up not because the company pays me. They don't pay me anything, unfortunately. I bring it up because there's new therapies coming out. There's new things coming out for patients with heart failure, and this is just one of them that has really improved the lives of our patients. There's a lot of attention on heart failure. There's a lot of research in it. We're doing some of that research at Queens, which I'll talk about. But that's what makes me excited, is that now we're starting to have options for patients that didn't have options before. So what are we doing here at Queens? I think there's a lot that we're doing, and I'll go over these in brief detail. I don't know how much time I have left, but we have a comprehensive heart failure center. We're working on a heart failure readmission project. There's valve procedures that we're just starting up in the next month, and then my specialty, which is advanced heart failure therapies. Okay, so what does it mean to have an advanced heart failure center? Well, Queens, has a lot of different institutes, and one of them is the Heart Institute. And there's all sorts of cardiologists and care that you can get. You can get care for heart attacks. You can get care if you have rhythm problems with your heart. So we're the Center for Advanced Heart Failure. And I think it's important to know that I'm not the only person that you might see on the team. In fact, I might be the least important person, even though I think I'm pretty important. But there's more important people, right? Like your primary care physician, like your general cardiologist. So most of the patients I see are sent to me by another cardiologist. So that might be your cardiologist, the general cardiologist. So we're trying to really make this a bit more robust and organize it so people can be seen in their own community, going to the west side of Oahu, right? Not just having care at this Punch Bowl campus, getting your care in a general cardiology clinic rather than having to see a specialty clinic all the time. This is Kapuna Montgomery. He's one of our leads from the administrative side, who's really working for us to have a comprehensive center for heart excellence, basically, and in particular for heart failure. So when I think about heart failure, we're talking about advanced therapies in part today, but most patients don't need advanced therapies. The majority of patients need chronic disease management. And we have Pearl Whitaker in the back of the room. She's been instrumental in working on the cardiac rehabilitation process for our patients, which will touch far more people than heart transplantation or a heart pump. When we think about the sickest patients who need a heart transplant, or even more sick, patients who get transferred to us from the Big Island or from Maui because they've collapsed, they had a heart attack. Their blood pressure is so low that they can't tolerate any medications. They come over for something called ECMO, or extracorporeal membrane oxygenation. And we have a great team here that's starting a program with Eric Itomen, who is my colleague and will help us lead the program, this is something that is not offered anywhere else in Hawaii. And I mentioned this already, but I don't care just about patients in Honolulu or even in Oahu. Queens has a footprint on the Big Island, on Molokai, and so I think, and frankly, we just got a transfer from Maui yesterday. So when we have a program that is specialized and has and can take of sort of any, the way I would look at it is, when I was at Stanford, we always said, well, we want to be able to take care of any patient in the country and get them the best possible care. And when I came here, I thought, well, why shouldn't Hawaiians get the best possible care and get that care in Hawaii? I don't like to see patients having to go to the mainland for their care. There's a lot of patients that can't make it to the mainland financially or logistically. It would be very unfair if we said, hey, you live in California, but you need to go to Hawaii for a heart transplant. So our job is to make sure that Hawaiians can get the best care in Hawaii. Heart failure readmissions doesn't sound very appealing, but it's appealing for patients, right? If you're a patient, you don't want to be in the hospital, right? You'd rather not be in the hospital. You'd rather be at home. And so we have a project at Queens. Queens is part of a nationwide research project that I'm faculty for called Connect HF. It's basically a way to standardize heart failure care. And Ryan Honda is the champion. And so another thing I want to emphasize is that heart failure care is not necessarily provided by a cardiologist even, right? Your primary care physician can treat you for heart failure as well. And so we're going to be partnering with our primary care group. Dr. Honda is a hospitalist at Queens, and he's done an amazing job in championing this effort. Queens is the highest enrolling center on the West Coast. So this is where Queens is sort of at the forefront, and the heart failure readmission rates at Queens are lower than the national average. I won't go over the study objectives, but the practical point for patients is it keeps patients out of the hospital, and it's an educational process. It's teaching patients, okay, when should you call your physician? It's calling patients 2 days after they get discharged. It's seeing patients soon after they get discharged. We're trying to ramp that up in our clinic right now. And so again, this is all the sites in the United States, and Queens is one of them. But we know that this can work. This is data from Stanford, actually, where I came from. And we had a very high rate of readmission for heart failure before we started our readmission project. And then about 3 or 4 years later, we'd cut that by more than 20%. And that's not something that I say that I'm proud of because the hospital likes it. Yes, the hospital likes it because it saves money. But I don't care so much about that because I don't see that money anyway. What I care about is that patients are not in the hospital because I want to see patients in clinic and I want to see patients at home. And that's something that we're committed to doing at Queens. So what about procedures? So there's all sorts of procedures you can get for heart failure. You can get a pacemaker, you can get stents in your heart to open up your arteries. One thing, so I talked about that medication called Entresto. It's one of the newest therapies that we have to reduce, to improve outcomes in patients with heart failure. This is probably the newest thing that's out there. So it turns out that when you have a weak heart, we talked about how the heart can get bigger over time. Because what happens is the heart can't pump out as much blood per beat, or the percent of blood, so it gets bigger, so it can, even though the percentage is low, the amount of blood stays the same, if that makes sense. You can't pump out as much percent, but you have a bigger amount of blood in the heart. But that's not good. The bigger the heart gets, the less efficient it gets. And actually, if you have this valve in the heart, the mitral valve, when it closes, it keeps blood from going backward. That keeps the heart efficient. The blood goes where it's supposed to go. When the heart gets bigger, that valve separates. And so that blood can go backwards and leak into the left atrium. That's bad. It makes the heart less efficient, people get more short of breath, and it makes the heart bigger over time. And so this is just an echocardiogram showing that, wow, this blood that's supposed to be going this way is all going backwards. And it turns out that you could do surgery for that, but there's a couple of issues. One is that it's a big procedure to have surgery. It's an open heart surgery, typically. Even if it's minimally invasive and you're not opening the heart, it's a lot of stress on a patient. And we're talking about someone already with a weak heart. That's more stress to put on. So some patients aren't even candidates for that. But now there's a catheter-based procedure where you can get this condition treated. And what happens is you have a catheter that goes through your leg, and it gets floated all the way into your heart, and it clips the valve. This looks like an alien, but it's actually a valve that's been clipped. And so that prevents the leakiness. And a lot of people thought, hey, this is crazy. You know, you're going to cause more problems. Is this even going to work? So the biggest trial that came out, and it was mostly US-based, just came out a couple months ago. And it showed that not only did it work to reduce leakiness in the valve, but people were living longer when they got this procedure, and people felt better. So we are starting our program in August, which is tomorrow, I think. And so I've already started referring patients for this, and partly because we were part of this trial at Stanford, and I saw patients who got better. So we're really excited that we now have this option in Hawaii and at Queens. And finally, I'll briefly talk about advanced heart failure therapy. So sometimes patients, despite having the medications, despite having the clip, they're still suffering. And so then we start thinking about things like a heart transplant or a heart pump. So this is a heart pump. And we're talking now again about stage D heart failure, patients who have gone through everything else. Well, why would you do a heart pump? Why wouldn't you do a heart transplant for everyone who needs it? It turns out we just don't have enough transplants available. This is a graph of the number of transplants done in the United States and the world over time, and you can see that it's sort of plateaued. But I just told you that there's more and more people who have heart failure and are developing heart failure. So if there's more people developing heart failure and the same amount of transplants, there's a growing mismatch between the people who need a transplant and the people who can get a transplant. And that's where this heart pump comes in. This is Peter Tsai, who's our cardiothoracic surgeon. He's going to help us start this program, hopefully in the next couple of years. But basically, you keep your heart. That's good, right? And then you have a pump that takes blood out of your heart and pushes it to the rest of your body. It looks really nice. This guy looks pretty debonair. But there are problems with the pump. Every pump needs power and electricity. So there is a line coming out of your abdomen going to batteries that you have to wear all the time. So this can be a problem, particularly in Hawaii, right? Although we have Hawaiians who have had this procedure and have done very well, because you can't go into the water. Well, I tell patients you can go into the water, but only once, because then you get electrocuted. So most patients, when they hear that, don't go into the water. But this pump procedure can prolong patients' lives. The longest running patient we had at Stanford is 10 years and counting. And it can also get people to a transplant who are not going to make it there otherwise. Another sort of more off-the-wall thing is there's a condition called amyloid heart disease, which is where a special protein gets deposited in your heart. For a long time, there weren't any treatments for that, but now there are. And we have the expertise at Queens to treat those patients, no matter what kind of disease there is. We had the center at Stanford. I'm hoping that we're going to have a center soon at Queens. So that's all I have for today, and now I think we'll take questions.
Thank you, Doctor. I want to make sure we get everyone's questions in. So if you have a question, you want to raise your hand to volunteer, and I have a microphone. If you want to just raise your hand, and we'll come on with the microphone.
Yeah, you mentioned earlier that alcohol and amphetamines can contribute to heart failure. My interest is in amphetamines. Would you consider things like high-energy drinks or caffeine stimulants in that category if you were to take them regularly?
So that's a great question. So the question is, we talked about substance abuse causing heart failure. What about high-energy drinks? And it turns out that caffeine is not a problem, which I hope is probably a good thing for all of you. Caffeine is not an amphetamine-like compound, and so it does not drive the heart. The problem is some of the high-energy pills, not necessarily 5-hour energy, but some of the ones that you might get at GNC could, or at a off-the-cuff pharmacy, could have amphetamine-like compounds in them. So most high-energy drinks will not have amphetamines, but you have to be careful and know what the ingredients are. And again, I would emphasize that caffeine is not contraindicated in patients with heart failure.
Okay. So things like Nodos or Vivarin, they would not be considered amphetamine then?
I want to say no, but I've never taken no-dose, so I don't know what the ingredients are. So you'd have to look at the ingredients, and as long as they don't have an amphetamine-like compound, the problem is what is that? It would be something called phentermine or something like that. So it won't say amphetamine on it. So patients come to me all the time and say, can I have this supplement? Can I try this? I just tell them, email me, and our team will figure it out and let you know if it's safe. You're welcome.
You just mentioned supplements. Can I ask you about some specific ones?
Of course.
Like carnitine, ribose, taurine, magnesium, and fish oil. Do you have an opinion on those?
Yes, I have an opinion on that. So the question is, what about supplements, and in particular, carnitine, taurine, magnesium, fish oil? I forgot the first one that you mentioned, ribose. Okay. So I'll tell you the exact same thing I tell patients in clinic. There's not as much evidence about supplements, and the reason is because many of them are not regulated by the Food and Drug Administration. And so one of the problems with supplements is, since they're not regulated, you often don't know how much of the supplement you're getting. You know, if you're getting carvedilol or lisinopril, you know how many milligrams you're getting within a reasonable standard error. So that's one thing. The second is, there isn't much evidence that supplements help patients with heart failure, but neither is there much evidence that they hurt patients. So I usually tell patients, I'm okay with you taking supplements. It's more likely that it will hurt your pocketbook, but it shouldn't hurt your heart. Now, the one exception of the ones that you mentioned is fish oil. There's pretty good evidence that fish oil can actually help patients with heart failure. There was a big study that just came out suggesting that patients who got fish oil and had a high level of a particular cholesterol in their blood called triglycerides had better outcomes if they took fish oil. And so I'm very okay with fish oil. The problem is you have to take the right formulation. This was a very special formulation that they studied. It turns out that fish oil can also reduce the risk of rhythm problems in your heart. So I'm very positive about fish oil use in my patients.
And what would be the dosage of the fish oil?
So it's usually 3 grams a day, but it's the specific doses of eicosapentaenoic acid, which would be hard for me to spell, but we can get you that information.
Does the lack of sleep, say for example, 5-6 hours of sleep affect the heart?
So the question is, what about sleep, and does it affect the heart? I think it does affect the heart, but every patient is different. Some people can get by on 5 or 6 hours of sleep, but some people need 8 to 10 hours of sleep. The way I look at it is, any stressor on your heart can cause problems, and anything that increases your adrenergic turn, your adrenaline in your body. One problem with lack of sleep could be, why are you having lack of sleep? It could be because you have a condition that's causing lack of sleep, like sleep apnea. So many of my patients with heart failure, so sleep apnea is a condition where you're sleeping, but you're not getting enough oxygen to your brain because the passages in your throat are closing off periodically. So you might snore a lot, right? So I screen a lot of my patients for sleep apnea with heart failure because that leads to worse outcomes in heart failure.
Protein powder.
Protein powder? So I have no problem with my patients taking protein powder. Again, you have to read the ingredient. So many of the protein powders that you see at GNC don't have salt added to them. Perfectly fine to use those. But if you have heart failure and you're getting a protein drink that has a lot of salt in it, that could be a problem. But the protein itself should not be an issue. In fact, I'm glad you brought it up, because a lot of patients with heart failure lose weight over time. They're gaining fluid, but they're losing muscle. And so it's really important to keep that muscle on, and I do ask those patients to eat more protein.
That's what I do.
You're good.
Do you treat any patients that come in with low blood pressure? They're not taking medications for it, but they have heart failure. And you mentioned the salt thing. Salt tends to raise blood pressure. Is it okay for them?
So it's a really good question. So the question is, what do you do for patients who come into clinic with low blood pressure and can't tolerate medications because their heart is so weak? And what do you do about the salt? Those are probably the most difficult patients to treat. And typically those patients, their heart is so weak that they're not tolerating medications. And that's why their blood pressure is so low, because their heart can't pump enough to generate a blood pressure. I don't think it's okay for those patients to eat extra salt, because then they tend to retain fluid even more than other patients. But you have to be practical, right? So I don't want my patients not to eat salt and become so weak that then they can't be a candidate for any sort of therapy. So when a patient's in that situation, we have to compromise a bit. And we're really thinking carefully about, okay, does this patient need a heart transplant or a heart pump? We have to get them to the next step because we can't use the medications that we typically want to use to improve their heart. Does that answer your question? Okay.
Well, they used to have like an article about like how fat is related to heart disease, and there's a movie like a couple of years ago say how that is wrong and people should eat more like healthy fat put more healthy fat into their diet. And I'm just wondering what do you think about like fat and related to heart failure?
So it's a good question. The question is, what about fat? And some people had said you shouldn't eat any fat because it could cause heart problems. And then more recently, there was some research suggesting that some fats can be good for your heart. Is that right? Yeah. So I think everything in moderation, really. When I tell patients not to eat salt, I don't tell them to take 0 salt in their diet because that's impossible. And you do need some salt, as you mentioned, to survive. And you do need some fat, too. Fat is important because it lines your nerves. And so you wouldn't be able to think if you didn't have fat. So the real question is, what kind of fat should you get? And I think there's a lot of controversy about that. So it really is about sort of having a balanced diet. I don't really counsel my patients about fat. I don't tell them that they have to have lower fat in their diet. I do talk to my patients about weight, though. It turns out that as you gain weight and you gain fat, you can also gain fat inside your heart. So at the extreme, there are patients who have gained so much weight that they have surgery, right, for weight loss, bariatric surgery. So they've done studies on those patients, and what they found when they did special tests like MRIs of the heart, they found a lot of fat in the heart in those bariatric surgery patients. And after they had bariatric surgery, that fat disappeared from the heart. And some patients who had very weak hearts got better. So that's an extreme example, obviously, but we know that you shouldn't get too much fat, but probably it's not reasonable to expect any patient, frankly, to take all the fat out of their diet.
Any other questions?
Doctor, the mitral valve clipping itself, is that typically because of an individual who has a heart that's already compromised? And number 2, is that something that is to address mitral valve prolapse regurgitation?
So the question is, what kind of patients are getting mitral valve clipping, and can it specifically address mitral regurgitation and prolapse? The answer is, to the second question, is yes to both. So it certainly will address mitral valve regurgitation. That's the whole point of the procedure, to prevent that leakiness. The big trial that showed benefit from the clipping was in patients with weak hearts, not with a mitral valve prolapse. There was a trial in patients with mitral valve prolapse, and that trial was more equivocal in terms of its results. But the main patient population that we think about are patients who have compromised hearts. Those were the patients that benefited.
Any other questions? Anything else? A couple more minutes. We'll take a couple more questions.
What do you normally recommend for patients who need a low salt diet, but who also are prone to conditions like hyponatremia?
So the question is, what about patients who need a low salt diet but have low sodium levels in their blood? It's a great question that you asked, because this is something that my patients ask me all the time. When you have heart failure, patients can have low sodium levels in the blood. So they tell me, hey, my sodium level's low. Why should I follow a low salt diet? I should be eating ketchup all the time. It's actually the opposite. We talked about the hormones that get secreted when you have heart failure. One of the hormones actually causes you to retain water, and more water than salt. So when someone has low sodium levels in heart failure, it's not because they have low salt levels in their body. The overall salt level in their body is the same or high. It's just that they have more fluid in their body for that level of salt. So any patient with hyponatremia, that actually is a red flag that they probably need more sodium restriction, in my opinion. There are rare cases where the sodium level is so low that we'll say, okay, we'll be a bit more relaxed about the salt. But that is maybe 1 in 100 patients that I see in my clinic. Most patients that I see in clinic who have a low sodium level, that's the patient I'm even more aggressive about in terms of lowering their sodium in the diet. Does that answer your question?
Do iron tablets affect the heart? And vitamin D supplement, from the pharmacist, the prescription one, like 50,000 or something?
So does iron affect the heart, and how about vitamin D supplements? So iron tablets are usually positive for the heart. There's been some research lately suggesting that if your iron levels are low and you get IV iron in through your veins, that those patients actually feel better. So I don't typically see iron supplementation as a problem for patients with heart failure. Vitamin D doesn't negatively impact the heart, but it's one of the conditions, vitamin D deficiency, that often comes along with having heart failure. So that's why it's so important not to just have a cardiologist, but to have a primary care provider, because we don't care just about your heart, we care about the rest of your body. It's not any good for anyone if we just think about your heart and we neglect everything else.
Thank you, doctor. Let's give the doctor a round of applause. Thank you very much, doctor. And again, it's not just the doctor. As the doctor mentioned, there's a whole team of people working at the Queen's, the team from Queen's Heart, and so they're all collectively, trying to help everyone out. So again, thank you again to the team at Queen's Heart, and also from the Hawaii Neurotrauma Registry Project. They were in the lobby earlier this evening, handing out some information and some pamphlets. And mahalo to our Queen's volunteers, Abigail and Tyler, for helping us out this evening. Our next Speaking of Health lecture here at Punch Bowl is going to be entitled Caring for Your Kidneys. Again, it's going to be talking about your kidneys. Chronic kidney disease is one of the biggest under-recognized health crises in the world today. Early recognition through simple screening tests is vital to slowing its progression. Now, here in Hawaii, more than 3,000 people are on dialysis, and a kidney transplant is an alternative, or can be an alternative, to dialysis treatment. We'll have Dr. Makoto Ogihara and Dr. Christy Izutsu. They'll talk about screening and detection of kidney disease, risk factors, and how to become an organ donor. Now, that'll be Wednesday, August 28th, from 5:30. Again, we're going to be starting at 5:30, not 6 o'clock, 5:30, a half hour earlier, from 5:30 to 7. It's here at the Queen's Conference Center. You can register online at www.queens.org. You can click on classes and events, or you can call the Queen's referral line at 691-7117. Again, we want to thank you very much for attending the Queen's Medical Center Speaking of Health lecture. Don't forget to get your parking ticket validated in the lobby, and make sure you have a safe evening.